So for those of you that missed my first talk, my name is Jennifer Turney. I'm one of the fourth-year general surgery residents at Tulane School of Medicine. And today I'll be presenting an abstract on PICC lines versus central lines and evaluating their safety in the clinical arena. I have no disclosures. So the goal for this talk is to give you a snapshot view of PICC lines and central lines and their use in a clinical setting via a large outcome database, and also evaluate both PICC lines and central lines safety using or identifying and comparing major catheter-related complications such as infection and thrombosis. So our methods for this paper were to use the Healthcare Cost and Utilization Project for the state of New Jersey from 2009 to 2010, which is a large outcome database sponsored by the Agency for Healthcare Research and Quality. It includes 90% of the hospital discharges within the state, including both urban and rural hospitals, public and private hospitals. And we wanted to get a population that had a large number of catheter insertions with the least amount of exclusion criteria. Many of the other articles published on this topic in the literature select a very specific cohort of patients, and we really wanted more of a macro view of what was going on in terms of PICC lines versus central lines. We used CPT codes to identify catheter insertions, and then we used ICD-9 codes to identify catheter-related complications of infection and venous thrombosis. So what did we find? The data was analyzed by each catheter insertion, not by each patient, and so we found 10,045 catheter insertions in a total of 9,941 patients. So 208 catheter insertions were excluded for receiving both a PICC line and a central line. And what we found was that there was an overwhelming prevalence of PICC line use. Roughly 95% of the catheters inserted were PICC lines, and only 5% of the catheters inserted in this year in the state of New Jersey were central lines. The ages were about average, 67 years of age for a central line and 66 years of age for a PICC line, and roughly about the same number of males and females received central lines and PICC lines. Females received just slightly more central venous catheters at 53 to 47, and males received slightly more PICC lines at also 53 to 47. So let's get to the meat of it. These are our results on infection. What we found was that central venous catheters were associated with a 4.88% incidence of catheter-related infectious complications, and PICC lines were associated with a 2.6% rate of catheter-related infections. So what we found, the risk ratio was 1.9, giving us essentially double the risk rate of infection when using central venous catheters. Now, we know that infection increases mortality, healthcare cost, and hospital stay, and these are all important metrics in the new healthcare system and healthcare world that people are going to be following. So this is an important data. For the most part, these results are congruent with the literature. There have been several studies that looked at, as I said before, specific cohorts of patients. There was two studies actually looking at patients receiving central lines versus PICC lines, getting parenteral nutrition, that found no difference in the infection rate. But the rest of the studies looking at patients in the acute care setting, in the surgical ICU, and oncology patients all showed a higher risk of infection with central venous catheters over PICC lines. Now, when you look at the rate of thrombosis, we found that essentially there was no statistical difference in the rate of thrombosis between PICC line and central venous lines. PICC lines had a total incidence of 2.5% thrombosis, and central lines had a total incidence of 2.9% venous thrombosis. And that held true for both deep venous thrombosis and superficial venous thrombosis. Now, other studies have shown that PICC lines are associated with a greater rate of deep vein thrombosis, up to 2.5 times the relative risk. So why is our study different? What happened? Well, first of all, this is a retrospective study looking at data from one specific year in one specific state. The studies in the literature that have shown greater rates of venous thrombosis using PICC lines were prospective studies. Those studies ultrasounded patients both before and after catheter insertion, regardless of whether the patient was symptomatic or not. So what they're picking up on is the occult or asymptomatic DVTs. That's what our study fails to pick up on. So by looking at just the symptomatic DVTs, there's no statistical difference between a PICC line and a central venous line. So what did we conclude from this study? There's an overwhelming prevalence and preference of PICC lines versus central venous lines. It's not really clear in the literature why this is. There is data to support a PICC line long term, as I just talked about, for reduced infection rates. There's also a time benefit for the physician. As we know, most hospitals have either a PICC nurse or a PICC team putting in the PICC lines, and the physician doesn't have to put in the time putting in a central line. Also, there's improved patient satisfaction with PICC lines. They're more comfortable. There's not a big catheter hanging out of your neck or your chest or your groin. So that may be one of the reasons. And then we also concluded that PICC lines are safer than central lines in regards to catheter-related infections, but that there was no statistical difference when it came to symptomatic catheter-related venous thrombosis. So what I want to talk about a little bit, or put the question in your mind is, are these asymptomatic DVTs important, and how do they affect the patient? We know that recumbent patients that are laying in bed in the hospital don't always show signs of DVTs, and we know that they may not be able to express their problems. So that's an area that really is not served well in the literature, and an area that needs more follow-up and study. Questions?